skull-base endoscopy. To start with, I would like all the participants to kindly introduce yourself so that we are aware what is your level and we can address your needs. Basically, this course we have divided into two parts. First day today we have kept it for the basic transfemoral approach, basic anatomy of nose, transfemoral approach, and how to reach it, and what are the various nuances of this area. And initial part of extensions of transfemoral approach like transplanum, tuberculum approach we will be able to cover today. We have with us Dr. Prakash Nair. He is a professor in neurosurgery at Sri Chitra Institute of Medical Sciences in Trivandrum. He will be our visiting faculty for the day, and he is a well-renowned national and international expert for skull-base endoscopy. He will be demonstrating the various types of endoscopic approaches to the sella and the various extensions of this approach today. And tomorrow we will be going to more advanced versions of this approach, mainly the trans-steroid approach. That also will be demonstrated by Dr. Prakash tomorrow. To start with, I would like all the participants to kindly introduce yourself so that we have a basic idea of your levels and we can cater to your needs as per your requirements. So, एक mic दे दो please. एक mic दे दो सभी को. To start with, we'll do the lamp lighting ceremony of today. May I request Professor Kamran for sir? He's about to. Sir वो भी आ रहे हैं. तो फिर ओके सर वो इनॉग्रेशन सिर्फ आपको सर को ही देना है ठीक है. I now request Dr. Chandra sir to kindly address the audience.
Professor Kamran Farooq, our most able and dynamic chief for the trauma center. And of course, my dearest colleagues, Rajiv, Deepak, and we also welcome Prakash for having taken his time to come here, Dr. Prakash Nair. So, for those of you who have been coming here for the first time, this is a very, very niche and a unique initiative. So, when Deepak came and discussed to me about setting up a series of cadaveric workshops, I advised him that please don't make it an affair where more than 50, 60, 100 people are going to come, and let it be just for 15, 20 people, but let's create an educational model where a one-to-one teaching is given and people who work on the cadavers will have almost a complete near operative experience of how they can look at the pathology or pathological substrate real hand. Because I believe you could have any kind of simulation, you could have any kind of devices, you can have computer simulation, AI, whatever, but nothing replaces a good cadaveric dissection, especially in well-preserved cadavers. And I think this is a big thing. And the reason is that if you want to go for any kind of similar workshops to Thailand or to some Asian country or even to US, it doesn't cost us less than $5,000. They are so expensive. And even if you go to places like Ramaya and all that, of course Ramaya has set up a very good setup. Then now other setups are also coming up. But again, they are also quite expensive. So the idea of setting up this kind of educational, morning Dr. Vijay Sharma, educational activity is that we should be self-sustaining. We will not like to take any kind of sponsorship from pharma companies, and we will run it in a very low-key kind of a thing. We will just see how we are just getting self-sustained, and we will ensure that only a few people come to this and they are able to learn it as well as possible. So from that perspective, I would like to congratulate, first of all, I would like to thank Professor Kamran as well as Professor Vijay Sharma for allowing this to happen in a very fully cooperative manner. So I have found Dr. Kamran to be an amazing person. So he's very accessible. Anything we want, you just give a phone call and immediately it's done. And I think that having this kind of administrative access is a big thing. And secondly, of course, I would like to thank my dear colleague Deepak for having the patience to do it again and again and keeping it well sustained. So usually most of the initiatives when they are started after some time, they don't, but he has kept it consistent, it keeps on happening. And then my own faculty over here, we have Rajiv and Satish. We run a very busy OR. So they have to miss their operations and come here and then participate in the workshop. They already have surgeries, they have the trauma center duties, they have the gamma knife, they have a load of other administrative work, but still they take out time and come here and participate in this educational activity. So thank you very much for all of you for having made it here. And I hope this keeps on continuing. And we will definitely look in a manner how it can be further expanded without diluting it. I think that's very important. So we can look at mechanisms how this can be done. So thank you and have a wonderful stay and have a wonderful workshop.
Thank you, sir. I now request Dr. Vijay Sharma, sir, to kindly introduce, kindly address the gathering.
Very good morning to all of you. On behalf of ACSST, I welcome all of you, and I appreciate the effort of Dr. Prakash Nair, who has come all the way just for one purpose, that is teaching and learning. And I know as faculty that faculty also learns a lot from all the courses. I think it's learning for faculty also. I think I was just showing census of last year to Dr. Deepak Agarwal, and congratulations to Dr. Sharat Chandra and Dr. Deepak Agarwal. I think they did the maximum courses last year. Last year orthopedics, they did one course ahead we were, but last year they did 3 courses extra. So we did 9 courses and total 270 delegates were trained. But neurosurgeons, they did 12 courses and 260 delegates they were trained. Now, because we have a system of auditing everything. And I congratulate Dr. Deepak for introducing such super specific courses like endoscopy, pain, white matter. I think I was just looking at all the courses. They are all very classic courses, I would say. So I would encourage all the delegates. I think you cannot get better faculty, you cannot get better cadavers, you cannot get better instrumentation. I think this is the time for you. So try to learn as much as possible and try to put that in your clinical practice wherever you go. So with this, I think again I wish you all the very best for the academic learning experience in the coming 1 or 2 days. Thank you.
Thank you, sir, for your kind words. I now request Dr. Deepak Agarwal to kindly address the gathering.
Thank you, Rajiv, and good morning to all of you. It is only with the support and blessings of our HOD, Professor Sharat Chandra, that we are able to conduct so many courses. And we continue to experiment with these courses. So, because there is nothing as perfection, so we keep trying to do new things. So for the last 2 courses, we have split the courses into 2 days, day 1 and day 2, day 1 being basic and day 2 being advanced, so that you can choose. Although all of you chose, 99% chose both days, but what we find is a lot of the delegates are still struggling with the basics, and they take time, so advanced course doesn't make too much sense for them. So that was our I think the genesis of this, but I think over time we will continue to improve. Also, we have the polling system and everything, the quiz on the app as a web, the web address. So I want you all to use that so that we get a feedback for every lecture and talk that we are having out here. And I think I see familiar faces all the time in these courses of ours. So I welcome you. This is just I think the more you do it, the better you learn. But I would like you to put it into practice because just coming here will not solve the purpose unless you go back and start doing also something. So I welcome you all again for this course. Thank you so much.
Thank you, sir. I now request our chief guest of the day, Dr. Kamran Farooqi, sir, to kindly address.
Good morning, everyone, and thank you, Rajiv, Professor Sharat Chandra, Professor Deepak Agarwal, Dr. Vijay Sharma, Dr. Nair, Satish. I welcome you all on behalf of Trauma Center. Already, I mean, most of the things have already been said. A few things that I would like to highlight is that congratulations to Dr. Sharat Chandra and Dr. Deepak Agarwal. He's a very visionary and a foresighted person. I mean, he's been like right in the beginning. He plans out all the courses. Like I'm a spine surgeon and arthroscopic surgeon. So we, me and Dr. Vijay Sharma, we keep discussing how many, and as time passes, we plan the courses, but Dr. Deepak Agarwal has already planned out all the courses, which is a very good thing. He's, in that way, he's visionary. Ever since I've taken over as chief, that we've been consistently doing so many courses, and that's a mandate of the institute actually, to teach and even impart education. So the second thing, Dr. Sharat Chandra has already said that if you go out to do these courses, it costs a huge amount of money. I mean, almost Indian rupees 1.5 to 2 lakhs. If you go out even to Asian countries, and I mean, we are not able to talk about European or American countries where the cadaver courses are very, very expensive. So it's a great opportunity that we have this facility here, and it should be utilized as much as possible. And we have the infrastructure, we have the cadavers, and the best thing is the same cadaver can be used for different disciplines. It's not necessary that if you are using the skull base, then it can be the spine can be used somewhere else, or maybe the abdomen can be used. So we try to optimize the use of cadavers. The other thing that I was just thinking that some of the courses which are being done here, especially the ENT guys, they're doing a course in which they have 2 candidates per cadaver, just 2 candidates and 1 faculty. So that's a fantastic learning experience, and the number of cadavers we have and the number of participants we have, like Dr. Sharat Chandra said, that we should not exceed 20 or 25 maximum. So it's a short of practicing on the patient. It's the best opportunity for you guys to learn and practice, and especially for a skill like endoscopy, because we do a lot of arthroscopy. So I know that unless you do it hands-on, however much you watch on the simulation on the computer, you won't get the feel. You have to something which are motor skills can best be. I understand that anatomy, even something open surgery, you have the basic surgical skills, but especially for endoscopy and those kind of motor skills, you're not actually looking, and you are actually seeing on the monitor, and then you hand-eye coordination and triangulation. That's very important to practice on the cadaver. Even if you do on the simulation, you watch on the computers, you'll just not have the confidence or the skill. So this is the best starting out point. So make use of this. Short of practicing on the patients, and then how it goes, we don't know, because the risk involved is too much if you practice first on the patient. So best thing is to do on the cadaver and make use of it. And like I said, you have a very good ratio of the participants and the faculty. So make maximum use of it, and I would say that share this knowledge and the fact that we are doing so many courses. I think there's a website. Just make a note of that website, and spread it across in your region, wherever the state you are coming, or the hospital, so that, because it's very cheap, and you won't get this opportunity easily if you travel out of, even in India you don't have. And like sir said, that Ramaiya is very expensive. If you see that from that point of view, AIMS New Delhi, with the amount of infrastructure we have, the cadavers we have, the C-arm, the scopes, the most of the instrumentation, if you go to other places, you won't have all the instrumentation which is required. In fact, we are trying to upgrade our scopy systems also. It was there, but I think it's been a long time, so we need to upgrade. But yeah, I mean, in future courses, so just spread the word around that this is a training facility which is available at Trauma Center AIMS, and make use of it. The other good thing is that Deepak never does it most of the times, not on the weekends, so that most of the people would like to do it on the weekends. They don't want to do it during the weekdays. So Deepak said, no problem, we can do it during the weekdays, so that we don't impinge on weekends, which is a good thing actually. So that leaves the cadaver, because most of the courses nowadays we see are done on the weekends. So the whole week the facility is not being used. So that is a very good thing that Neurosurgery, they agreed to use it during the weekdays also, which is a very good thing. I mean, we are maximizing the utility of our cadaver as well as the lab. So thank you very much everybody, and congratulations Deepak, keep it going. It's a feather in the cap for Trauma Center as well, and obviously it's teaching, and so many people are learning. Ultimately we are doing all for the benefit of patients, and the more we learn, the more we practice, the less the more expertise we'll gain, and better we'll be able to translate the benefit to the patients. So congratulations and thank you so much.
Thank you, sirs, for your words of encouragement and for your guiding words, and we will try to achieve all the goals you have set for us. Thank you, sir. Now coming to the vote of thanks ceremony, as the organizing secretary, I have been assigned this difficult responsibility to deliver this vote of thanks. First and foremost, I would like to thank Professor Kamran Farooqi sir, Chief Trauma Center, under whose able leadership ACSST is immensely contributing toward the teaching mandate of AIMS by imparting surgical skills to our young trainees and preparing them for the complexities of the modern surgical care. I thank our HOD Professor Chandra sir, who is the chairman of this workshop. I thank sir from the bottom of my heart, and for all his guidance at each and every step of the workshop. Sir has personally checked each and every aspect of this workshop personally at organizational level. I am thankful to Professor Vijay Sharma sir, in charge of ACSST, for providing us soft emballed cadavers in very good condition and a very ambient and academic environment. I am thankful to Professor Deepak Agarwal sir, who is the course director of this workshop, for giving me an opportunity in organization of this workshop and for guiding me in navigating the various hurdles for organization of this workshop. I am thankful to Dr. Prakash Nair, Professor, Department of Neurosurgery, Shri Chitra, for taking time out of his busy schedule and for dedicating 2 full days for this academic feast. Heartfelt thanks to my dear friend Dr. Prakash. I am thankful to Dr. Rakesh Kumar, HOD ENT, sir will be joining us tomorrow. Sir has agreed to contribute academic content to this August gathering at a very short notice. I am thankful to Dr. S.B. Ray sir, HOD Anatomy, and his team for providing us cadavers for this workshop. I am thankful to my departmental colleagues, especially Dr. Dattaraj, Dr. Ramesh, Dr. Rajesh, Satish Verma, Dr. Surya and Shantanu for their support and timely help. I am thankful to all my residents who has helped in organizing this workshop. I am thankful to Carl Store's team, especially Manish Thakre, Anupam Tomar, Sunil Verma, and Suraj for providing logistic support for this workshop, though after a major hiccup which gave us sleepless nights. This workshop have been impossible without support of Carl Stores. Special thanks to our sponsor, Sun Pharma team under the leadership of Prasenjit ji. It's practically very difficult nowadays to organize academic events without their support, not only from financial point of view, but also from manpower point of view. I am thankful to them for doing the work responsibly and meticulously. I am thankful to various vendors like audio-visual team under Ravinderji, Gagan, Manish for making the arrangements for this workshop. I am thankful to ACSST staff, especially Naseem and Manoj and Pooja, who are working tirelessly in the cadaver workshop for making arrangements for today and tomorrow. I am thankful to our office staff, Neha, Vinay, Divya and others for helping us in organizing this workshop. I am thankful to all of you, especially the delegates who come from far off corners of the country to contribute to this educational activity. Last but not least, I am thankful to all the families of the cadaver donors for giving us an opportunity to learn on the body of their relatives. I pray to Almighty to grant moksha to the Atma of these cadavers. Though we tried our best to make all the arrangements for this workshop, still there might be some lacunae left for which none else than me should be held responsible. Last, I would like to extend a heartfelt vote of thanks to all those who made today's event possible, whose name I could not highlight due to shortage of time. Thank you all for your invaluable contributions. I now invite everyone to kindly come on the dais for a group photograph. I request Professor Chandra sir to kindly deliver his talk. Topic of sir's talk is transseptal endoscopic approach to sella and suprasellar region. Professor Chandra sir.
So good morning everybody. So this is something which I have developed on my own. And of course now some other people are also doing it, and this was all, I think it's all, I've been doing this technique for more than 7 to 8 years, and of course I need to publish it, otherwise it will lose its credibility. But yeah, we are looking at our data, we have more than 100 cases, but I really like presenting this. Now couple of reasons what I think about endoscopic technique to pituitary. So I feel the bread and butter are pituitary adenomas for an endoscopic technique. And I think they constitute about 80%, 70-80%. And then you have another 20% which could be other lesions, cranial. So pathologies like meningiomas or something, personally I don't want to do it endoscopically. The reason is it gives a very big, at least I have seen couple of cases where I've done, and these patients had complaint of severe loss of smell. In fact, one patient said that she doesn't enjoy chart or anything. She has lost her entire interest in her whole life, and she's lost a sense of smell, and she actually went into depression. She had to be treated with antidepressants and all that. So for extended approach, somehow, yes, definitely we think it could be useful in some conditions, but for conditions like meningiomas or so, I feel it's always, if I do a Sokha approach, I could finish the tumors in just 15-20 minutes. So I find that very convenient, and I personally feel that the sense of smell is very, very important and it needs to be preserved. And for some reason in this rush of minimally invasive and all that, we have forgotten how important it is. We don't give too much of importance to this. So I'll just skip all these slides. So if you look at contraindications for a transnasal approach, one is obviously a tumor which is extending into the anterior middle, but again extended approaches can be done. Now doing a transcavernous or extended approaches for pituitaries is a good option, but again one needs a significant training in that, and even with very good training the patients can end up with some deficits which may not recover. So unless you have some experts who have been doing it for many years, I sincerely feel that if you have a cavernous lesion going, pituitary going, particularly if it's a non-functional, you can leave it because it's something which can be treated very eminently with gamma knife. And these are some of the contraindications for trans and nasal approaches which you should be aware of. So dumbbell configuration is something which we often miss out. And I have seen couple of cases, you just cannot access, in which case you have to cut the diaphragm sellae, or sometimes you have to do a transcranial approach. And sphenoid sinusitis is again a relative contraindication. And obviously meningiomas, I wouldn't like to do it through an endoscopic approach. Sometimes, you can make out an MRI that the tumor is going to be highly indurated. Again, this is a relative contraindication. Ectatic kissing carotids is one important contraindication which you should be aware, because sometimes you could end up in a disaster, not because you are going to damage the carotids, but in about 4% of the cases there could be an incidental aneurysm which may be associated. So whenever there are kissing carotids, I always prefer to get an angiogram done. Now this kind of giant tumors, obviously the best way to do it is from a transnasal approach. There is no question about it, because if you try to do it through a transcranial approach, you are going to devascularize it, the tumor is going to swell up, it's going to be a mess. So the whole idea is you need to take it from below. Now right from the time when I started doing pituitary endoscopic approach, I felt most of these instruments are not required. When you meet a vendor, especially people who are sponsoring workshops, you go out. Is Sunil sitting here from Karl Stores? He's outside. So since he's outside, you meet people like Sunil. So they will say, sir, aapne dekh liya. Now you please buy our 64 set endoscopic set. So I feel most of these instruments are not required. Now if you look at history of transseptal approach, it was originally described by Hirsch in 1940. And at this time they had given up because he used to use a lot of retraction and there were septal infarcts, and so they gave it up, and then they started doing other approaches. But if we can keep, obviously the advantage is that you can have an uninasal approach, it can be a midline approach, and if you can raise a very nice flap, it could also potentially prevent CSF leaks. And right from the beginning, even though many people would say that you do this biportal, binasal approach, I was never comfortable with this. Because I always used to feel that this is an unholy entrance into the nasal cavity and you're kind of, destroying a lot of these things. And right from beginning, we have undermined the amount of nasal damage that can produce. Now this was one of my own earlier cases. it was a standard pituitary where I did a biportal approach. One of my earlier cases, I had called an ENT surgeon also, and then patient had some recurrence, I had to go in again. Now you can see there is no septum left, and patient had complete loss of Nell, severe atrophic rhinitis. Of course, we do more minimally invasive. There are surgeons obviously who will say, I have never seen such a case, I have never seen such a complication, but I feel that if you do some approach like a binasal approach, you remove the posterior part of septum, when you are creating situations, the complications are more likely to happen. And the reason they can happen is that whenever we do extended approach, we always take off the main feeding arteries which are at the base of the skull and from the sphenoid. So when we do a biportal binasal approach, I don't know how much Prakash will agree with me, but we end up damaging all these arteries, and then we produce a very fertile bed for complete loss of smell and for atrophic rhinitis and all such issues. So for pituitaries, I use a transseptal approach, and I keep things very simple. Somebody told me that a surgeon should always follow the KISS strategy. Keep it simple and stupid. So I really like following that strategy. So everything should be as simple as stupid, because then your SOPs are very straightforward. It's a very linear SOP. So less chances for you to have any complications. So this is what I use. Obviously I use an endoscope. I use the regular pen-filled dissectors. I really find the other endoscopic instrument, what I really find useful is a scalpel with a retractable blade. Now except for these two instruments, all the other instruments are standard non-endoscopic instruments. This is optional. You may or may not get it, it's up to you. Most of the cases I don't actually end up using this. Similarly, antrum punch also I think is not required. I hardly use them, and of course setting up the OT table is very important. Now how you set up, so generally I do it in the simple way by which you can enter, as we used to do for the microscopic TNTS. Now pre-operative it's very important to do a nasal inspection, spatula test, nasal decongestants, no nasal antibiotics, antibiotic policy as per the department protocol. So we place the patient supine, 15 degrees, turn to the opposite side, everything standard. And then I'll show you the video. Can I take this phone, Deepak? It's for my OT. Aparajita? Okay, thanks. So how do I do it? So I worked with multiple patents. I can show you some patents also. I thought I'll create a retractor and all that. I even got it patented. I gave it a very fancy name called as Easy Track. And then I spoke to the people, some commercial, they made a prototype. Then they said unless it is sold for 10,000 rupees, it's not going to be of any use. Karl Strauss people were not interested because they thought that will reduce the number of instruments to be used. Then I came across this simple thing. Take an MRI film and measure the size of the opening. Use a scale to measure it and just double it and create your own retractor. So this is what I do for all my cases. Fold it, and you can curve the anterior part so it is curved, and now you have an excellent retractor which is a dynamic, non-reflectile, and you can navigate it into any direction you want. Now most important is now here I am using a monopolar, but nowadays I don't use a monopolar, I just use a knife. So at the mucocutaneous junction, make a opening, reflect a very nice mucosal flap. This has to go right up to the base, and in this case I would like to use navigation for a couple of reasons. A, because we have it. 2, I don't like to unnecessarily expose myself to X-rays, and B, it gives me a very nice trajectory of access to go there, but it's not mandatory. If you have an X-ray you can use it, and it's not required also. If you know the anatomy well, it's not required. Slip in the retractor. Now, using a number 1, you fracture the septum to the opposite side, and moment you do that, you will start seeing the normal, usual anatomy what you require for a pituitary. Now, over here, you can pass the endoscope along the 12 o'clock position. So that's a keel of the vomer, and you can use suction to keep on retracting the mucosa from either side. So you are now using the endoscope along the 12 o'clock position. So the only movement your assistant has to do is out and in movements. That's it. He doesn't have to go anywhere. And now this retractor prevents any blood from coming inside. It is non-reflectile. It is non-damaging, unlike the Hardy's speculum. And it is dynamic. You can also go to any direction you want. And then most important, you can push it inside the sphenoid sinus, which you can't do with an Hardy's speculum. Because if it goes into sphenoid sinus and you open up the Hardy's speculum, what you will have? Anybody? Let us say if I push Hardy's speculum into sphenoid sinus and then I open it up forcefully, what complication can you have? Any delegate? You can have an optic nerve strut fracture. So in this case, you can push retractor right up to the opening of the dura. Then of course I raise a flap so that I can, and then that's a regular. So this is a more recent video that I did, so you can see how it is done. So I don't use a monopolar, and at the end of the surgery I put a stitch, and if the hemostasis is very good, I don't even need any kind of nasal packs. So it's very important to first create an initial mucosal flap, and a submucosal tunnel has to be created. So that's how we measure it, and that's how I'm making the retractor. So twice the size of the, and of course it has to be curved from the front, which has not been shown here, because for some reason he was not able to record it. And it's a very inert material, so you can just sterilize it. So you come to the usual anatomy, and you can reach there. So I prefer to raise a bone flap and push it down, and then it can be pushed up later on once the tumor excision is over. So this flap can be turned down. And of course we start removing the pituitary, first from the posterior part, then from the lateral part. And you can see rest of all the endoscopic procedure is absolutely very well visualized. You don't have any impedance, and the only movement that your assistant has to do is in and out movements. And I can see at the end, we just put a suture, and at the end you can see both the nasal cavities are pristine, completely well preserved. So any blood clot which is there can be sucked out. So this is a technique which has been described well, but people don't actually realize it. So once you remove the tumor, what one needs to do is, you will have an arachnoid bulge, and it will give you a false impression that you have removed the tumor completely. So then in which case I prefer to take a piece of gauze, and the reason you prefer to gauze over cotton is you can really suck over it and keep it dry. But you have to be careful that no fibers are left behind. That could be one of the potential risks for using a gauze. And it can be pushed up with a suction. I call this as a tenting technique, and when you push it up, then you will start seeing the tumor along the sides. So ideally you should first remove the posterior part and then the lateral parts, but in big tumors there is always an inherent risk that the arachnoid will bulge and come on the way. So you will have to use this tenting technique, so that when you push up the tent or you push up the arachnoid, you will start seeing the tumor all around it. And I'm not talking of any transcavernous approaches, I'm talking of a standard excision for a pituitary tumor. Of course, this was a retractor which I developed first. We called it Easy Track, I got it patented. We went through a lot of efforts for this. But then I realized a couple of things. I realized, you can see over here we are raising a submucosal tunnel. So, and it was a very good retractor. So you just open it. So it had a wire which has to be pulled out. I'll just show you. So that's a submucosal tunnel. And it was a single use retractor. The only problem here was, we couldn't just see eye to eye with a commercial person. So you had a wire. So moment you pull out the wire, the metal will deflect and then it will get deployed. So you can bend both the ends. And then you could put a section inside. And that fractures the septum to the one side, and then you see the usual anatomy as you can see here. So you can see the sphenoid ridge, and you can see there is a retract on both the sides, and you can see everything. And raising an Haddad flap is very easy here because you already raised a submucosal flap. You just need to cut it above and below, and you can harvest it as a Haddad flap. You don't need too much of dramatics to put a endoscope and then try to harvest it. Now in the end I just wanted to run this video to show that in the end you just put a stitch, that's it. So if I don't have a CSF leak, I bring the septum to the midline, and then I don't know why it stopped here. So you just put a stitch, you don't have to even use a Merocell in the end. So we made a unique retractor when I was operating this giant, and there's a few cases where we have used it. So this is one of the complications I had. We had some other cases. With this we had to do it in 2 sittings. So this is a pretty old presentation. So the bottom line is that we were earlier actually doing a transnasal approach where we would use a hardy speculum and go to an axis, but we gave up that. It had its own intrinsic advantages because you had a midline perspective. But then came the endoscope, then you started entering the nose. And then the ENT surgeons came, and they told you to hold the nose from the other side. They said, don't hold the nose from this side, hold the other side. And then came in the people with the endoscopes. They said, you please buy my 70 item set, you please buy my 80 item set. But at the end of the day, if you look, 80-90% of these tumors are standard pituitary tumors, for which the only instrumentation you require is an endoscope and maybe a retractable knife. And most of the other instruments are standard instruments that we have always been using as a neurosurgeon. And using the transseptal approach with an MRI film, which is very simple, you just sterilize it and use it, helps you to bring back to your roots. It helps you to bring back onto that road which you are always traveling. You don't have to take a bypass to reach to something where you have been doing for several years. So it brings you back to the roots and aligns you onto the midline so that you can approach it. And this is an approach which you would be using for 80% of your cases. And once you get used to it, then you can think of doing cranios, then you can think of doing maybe transcavernous approaches, you can go to other things. But believe me, even in large tertiary institutes, they constitute a small portion. And even over here, when the surgeons feel that it's too much of thing, we leave it and we give gamma knife. I send it to Deepak. Deepak gives gamma knife. We have excellent survivals. And of course, with experience, there are surgeons who are removing transcavernous, they're getting over there, they're going, those things are there. But again, I feel that it's not something which everybody should do. So this was a short presentation and also a bit of my philosophy on how we evolved this. If there are any questions, I can take up.
Sir, I just want to comment, sir. Excellent presentation, sir. I recently went to an endoscopy conference in Jabalpur, and 30% of the talks had shifted from binostril to uninostril because of the complications of binostril, including loss of smell, sexual desire, so many things they mentioned. And even in uninostril, now they're coming down to a kind of approach which you just showed. So I think the whole clock has turned back on itself.
So
now.
I've been doing this for 7 years.
And this must be your experience also.
I think I have done nearly 1,000 cases of endoscopic this. I have only done one case of uninostril this. All my cases are binostril. But I think my focus is more on the fact that we also do a very thorough post-operative management. And none of our extended outcomes will be good if the patient is not going back to an ENT surgeon for regular this. So for example, morbidity for ACF tumors is much more than morbidity for a pituitary tumor. And morbidity for a patient who has an open maxilla is definitely more. So unless we also manage those patients post-operatively with adequate endonasal management, outcomes will be poor. But the advantage of this is not the fact that your corridor can be wide, and also that it gives you a very unique anatomical access on the undersurface of the optic chiasm.
And one more thing, I feel it is very short learning curve, sir.
Yes,
compared
absolutely.
to anything else. For those who are not confident, this is the right way to begin endoscopy.
So when I do pituitary, less than a minute I am on the sella.
Yes, sir.
It's very fast. And then within half an hour the tumor is over. I'm talking of standard pituitaries.
So I think this is the right way to start because this is the natural extension of our microscopic techniques.
Absolutely.
And then we can progress if we want to any direction.
And yeah, one thing is this can never be patented because it's a zero cost. I'm sure a lot of surgeons will take it up. And we also need to get it published. It's been 7 years. So I've been a bit lazy about its publication. I have the data. So let's hope I will be able to. And when I presented it, other people started doing it. So, but yeah, unless you publish it, nobody will say. After some time, it becomes so common that, it doesn't look anything unique. So I presented this almost 6-7 years ago when it was the holy grail to do binasal, going and doing even a turbinectomy and then removing it. And when I presented it, some people got up and they were aghast. They said, how can you, there is no space, you cannot do uninostril, you have to binostril, you need so much of approach. There was obviously a sense of insecurity. There's a procedure. But we have been doing this for many, many years. So at least for the standard pituitaries, I think this is a very simple way to do it.
Thank you, sir, for demonstrating a very innovative technique of assessing the sphenoid sinus using your innovative technique of using that X-ray film. And so it's a very economic way of reaching that. Any questions from delegate side?
Yes, Sunil.
Thank you, sir. Very excellent presentation for the beginners to begin with. If a patient comes to you with the inferior turbinate hypertrophy along with concha bullosa, how easy is your tenting technique in that case?
See, when we were doing transseptal microscopic approaches, we would not even look at the nose. We would go in the midline and we would get there within a minute or so. So it's only when we started going through the nose that we started saying there is hypertrophy of inferior turbinate, there is this, that. It doesn't matter. When you're in the midline, you use this technique, it's a standard pituitary tumor. Maybe I take less than a minute, other people will take maybe 3 or 4 minutes, 5 minutes, 6 minutes, you're there. It doesn't matter. You can have bilateral turbinate hypertrophy, it doesn't matter. You're there. So I started using it even for endoscopic extended approaches. So I've done it for chordomas, I've done it for some craniopharyngiomas. But I am super selective about this. Because cranios, I prefer most of them can be done transcranially. You can do through minimally invasive, you don't require. Chordomas, of course, if they are there going down into the clivus, you can do this approach. You just need to go use this approach to go right up to this. But yes, hypertrophy of turbinate, all that are not. Those are issues if you go through the nose. If you go through a midline perspective, absolutely no problem.
Okay. Even
So the length has to be adequate. So what you can do is once you go and push it in, then it protrudes out so much, then you can cut it to whatever extent you want. And when you open up the sphenoid sinus, it goes right into the sphenoid sinus. So you can push it right into the sphenoid sinus. It's a dynamic retractor. So if it goes very close, you can pull it out. If it goes too much above, you can push it inside. And if it gets spoiled, you can get one more easily. And it's very thin. It's actually thinner than the one I patented and got it made. That's a metal. That occupies more space. This is paper thin. And it protects all the bleeding. There's absolutely no bleeding. It reduces your equipment need just to 2 instruments. That's it. Sunil here is worried. I know he's worried. Don't worry. We have volumes in India. But for pituitary, you don't require more than 2 instruments. You just require an endoscope. You retract. At best, you can use number 11 blade with a bayoneted. You don't require that also. But I prefer using a retractable knife. All the others are standard equipment which you use for microscopic pituitaries also.
You can input all 3 instruments inside? Scope and
3, absolutely. That's the beauty of it. I can even put a bipolar. I have those videos. I was searching. I can use a suction and a bipolar like a normal operative procedure. Because the whole thing expands. You have so much of space. Even in kids, I was able to do that. Okay. But yes, in most of the cases, you can put in 3 instruments. And it's all so beautifully covered. There's no bleeding there. You have a very nice, preformed, non-reflectile tract going right up to the tumor.
And you remove the wormer every time.
Remove the?
Wormer.
Keel of the wormer, yeah, that's a standard. That's a standard for any. I mean, is there a way not to remove it? I don't know. Yeah.
No need to
Sir,
put
yeah, that's what I was asking.
You can do all that if you want. So that's beyond the purpose. But the advantage is once you pull it out, you can just put a suture and bring it close. And you may not even use a Mirocell. So let's say it's a standard pituitary, no bleeding, bring it out, put a suture, bring the septum to the middle and leave it. There's no need to even use packs. But I'm not quoting that this is the advantage of this. You can always use a pack. You can remove it and there's no problem of that. But I'm saying that it's very nice and minimally invasive. That's what I'm trying to say.
As
where do you keep the folded part? Is it pointing upward?
The folded part is towards the 12 o'clock position. So the film is, do I have it? So if I fold the film like this, I take a scissors and cut it like this. So this is kind of convex. And this is pushed so that this is at the 12 o'clock, this is the lower part. The endoscope goes only in the 12 o'clock position. So the only movement the assistant has to do is in and out position. That's it. He doesn't have to do anything else. It's very simple for the assistant also. He only has to do an in and out position.
What if there is a CSF leak?
Standard. You again do the standard things. So you can pack it, do everything, and you have a ready-made head-out flap. So you just need to cut upper and lower part of the mucosa, harvest the head-out flap and put it on that. So everything is standard. Everything is absolutely standard. There is no difference of management here.
Sir,
So for my CSF leaks, I never had to create a mucosal flap. So what I did is I used a tri-layered flap. So inlay graft, and then I would put some fat with inlay graft, and then another fascia on the surface with the glue, and that worked with me. So having a CSF leak doesn't change any kind of management. Facial atta, I found it sometimes too thick. Yeah, you can take it. So I take it from the abdomen. I found the rectus sheet is much more better.
Thank you, sir.
sir, one more question. Sir, do we need to inspect the ostium, sphenoid ostium and all those things, but we do in usual?
So when you reach to the keel of the vomer,
Yes, sir.
finding the sphenoid ostium becomes secondary. So you need to find sphenoid ostium only when you are going from the nose. But here you are going directly to the foundation. So the only reason you need to identify sphenoid ostium is when you retract the mucosa with the suction, it has to be retracted up to the sphenoid ostium. So it becomes a secondary objective, it's not a primary objective. So once it reaches up to the sphenoid ostium, then you can remove the keel of the vomer and then you can go into the cella.
Thank you, sir.